So for the one who survived, I'm going to give my last talk on the biology of locally advanced breast cancer. I will focus this talk on inflammatory breast cancer. So we will see the definition, how to diagnose an inflammatory breast cancer, and the biology and the difference between locally advanced and inflammatory breast cancer. And also the difficulty that we have to discriminate between what is a true inflammatory breast cancer and what is a locally advanced breast cancer that moved to an inflammatory breast cancer during the evolution of the body. So what is the definition of a locally advanced breast cancer? It's either a T4A, so with an extension to the chest wall, or a T4B with an ulceration, ipsilateral skin nodules, or skin edema, so what we call peau d'orange, orange skin. And when you have both, so if you have extension to the chest wall or skin ulceration or edema, it's a T4C. So this is the definition in the PNM of locally advanced breast cancer. The T4D is the inflammatory breast cancer. So it's when you have an erythema where the skin overlying the breast is usually pink or mottled pink hue with a sensation of heat. So it's a clinical definition. It's not an histopathological definition. The inflammatory breast cancer, the true one, is a rare and aggressive variant of locally advanced breast cancer. So it's a clinical definition, it's a T4D, and you can have exactly that. So you have one normal breast, and the other breast is enlarged, is hot, and there is a sensation of heat by the patient. It's red, enlarged. It represents between in France it's between 1 and 2, up to 5 to 10% of breast cancer. So we can say worldwide it's 5% of breast cancer. It's a very aggressive disease with 5 years survival rate of 40%. There is a rapid progression with a diffuse erythema of more than 1/3 of the skin overlying the breast. And this is the difference between inflammatory and neglected locally advanced breast cancer. And you can see here you have the red, the skin nodules also. And you have edema and enlargement of the affected breast associated with an exaggerated hair follicle pits looking like orange skin or orange peel, and a sensation of heat by the patient. The evolution is a dramatic change in color from pinkish to dark red or purple in a few days, with a diffuse spread over the entire breast, a generalized induration of the breast, and a skin ulceration and necrosis. So it's a kind of medical emergency. But you know that we don't do surgery to those patients. They are not candidate to surgery. They are candidate to general treatment plus minus radiation oncology. So differential diagnosis, and it's important for the clinician to be sure that it's not an inflammatory lesion like an abscess, mastitis, galactophoritis. So they can do an antibiotic treatment, for instance, to look if there is a modification or not. It can also be a metastatic carcinoma to the breast that can have a that can mimic an inflammatory breast cancer, and it has been described in the literature, ovarian, gastric carcinoma, sometimes squamous carcinoma. What is very difficult, is to make the difference between primary inflammatory breast cancer that developed in a previously normal breast and a secondary inflammatory breast cancer where you have the development of an inflammatory change that can mimic primary IBC either in a breast that I already had cancer or on a chest after a mastectomy. And this is the case here, where you have a secondary inflammatory. So also in this condition, it's very difficult for the patient to accept this kind of local recurrence. How do we diagnose an inflammatory or locally advanced breast cancer? There have been an international expert panel in 2011 that has described how to do the standardized diagnosis and treatment for inflammatory breast cancer. First of all, at mammograph, there are some aspects with a vanishing of the subcutaneous transparency, a skin thickness, and a breast global hyperdensity that are very suggestive of an inflammatory breast cancer. Of course, the cutaneous biopsy is very important, and it can be by scalpel, but it can also be performed very easily with a punch. And it can help, and the reason why we do that is to identify dermal embolies. The problem is that with both skin biopsies, we don't always find embolies. They are absent usually between 50 and 25% of the cases. So here the diagnosis will be clinical. Those embolies have to be seen in the papillary and reticular dermis of the skin, like it's shown on the picture. And it can be seen also sometime in locally advanced breast cancer. And when those embolies are in the derma like that, it's called an occult IBC. So it's suggestive of an inflammatory breast cancer, and usually the clinical course is more aggressive. But sometimes we only have dilatation of the lymphatics without any embolies inside. In terms of histopathology, it's not specific, but we can find skin thickness if we have on the skin biopsy up to 8 millimeter, where the normal thickness is 1 millimeter plus minus 0.2 millimeter. So it's really an important thickness. And it can be, usually it's a ductal carcinoma, but it's usually high grade, but it has been described in the literature as being less compact than the other tumor, with large areas of tumor-free zones. Usually there is no DCIS in a true inflammatory breast cancer, and there is a node positivity in 60 to 80% of the cases. What is the biology of those tumors? If you compare the large study from Algeria, which is one of the study that we very frequently refer to, they have compared inflammatory breast cancer to non-inflammatory breast cancer. You can see that in the inflammatory breast cancer, we have a majority of ductal carcinoma. You can have some cases that are micropapillary, but are they really micropapillary or are they large embolies? We are not completely sure. But you don't find the other type of tumors in this series. Here you have, in terms of node positivity, you can see in the inflammatory or in the locally advanced, you have higher level of node involvement, but you don't always have the data because the patients are not always having surgery. And if you look at the grade between non-inflammatory and inflammatory breast cancer, you can see that you have a higher number of grade 2 and grade 3 than in a general population of ductal carcinoma. In terms of ER and PGR positivity, you have in the inflammatory breast cancer a little less of ER and PR positive breast cancer, more cases that are negative, but it's not very different from locally advanced breast cancer. And if you look at the literature, and we will have some data at the end of this talk from the consortium of inflammatory breast cancer, you have a higher level of HER2 positive cases. But it's probably too high when the series where you have close to 70%, but it's at least the double at what we have usually in breast cancer, in regular breast cancer. In terms of molecular subtypes, so it was performed on tissue microarray, and you can see that in the inflammatory breast cancer, you have a higher representation of cases. This is not percentage, and this is number of cases, but you have a higher representation of HER2 and basal-like tumors in the inflammatory breast cancer. But you can have also luminal tumors in this group. The group of Thérèse Sorli and Chuck Peru have looked at the different classes of locally advanced breast cancer. It was in one of the seminal papers of the group, the series of breast cancer in one of the seminal papers was only locally advanced breast cancer, in large majority of the case, 75%, and you have absolutely a non-specific distribution in the locally advanced. So in the inflammatory, you have probably more triple negative, more basal-like triple negative and HER2, but in the locally advanced, you can have any subtype. If we go back to inflammatory breast cancer, so mainly ductal, high SBR grade, node positivity, HER2 amplified and hormonal receptor negative are more frequent, and of course a lot of vascular embolism. They have some characteristics by immunohistochemistry that have been described by Emmanuel Charles-Geoffrey group in Marseille. They are E-cadherin positive, HER2 positive in many cases, and MUC1 positive. And they describe a kind of immunohistochemical IBC signatures with E-cadherin, ER, MIB1, Ki67, MUC1, and HER2. And in their series of breast cancer, when the tumor was having all the parameters, you can see here that the prognosis is not good in a non-inflammatory breast cancer. So it's a kind of inflammatory breast cancer signature for also the other type. If they don't have all the parameters, the prognosis is good. If they have all the parameters, the prognosis is poor. And usually the inflammatory breast cancer has between 4 and 5 parameters, and the prognostic is poor too. So this is the definition of inflammatory breast cancer immunohistochemical features that can be applied to different types of breast cancer, and that when they are present are associated with aggressivity. So most often in the inflammatory you have HER2 amplified basal-like breast cluster. You can also have some tumors that are clotting low. It's also this group in Marseille, they have worked a lot on inflammatory breast cancer, and they look at gene expression in inflammatory breast cancer. What did they find? They find that they have some genes that are highly upregulated in inflammatory breast cancer, such as the ROD-C GTPase, which is a member of the RAS homology GTPase family. And they are involved in cytoskeletal reorganization during invasion. So this could be an explanation of the feature of this type of tumor with the skin invasion. It's important because they are targets of farnesyltransferase inhibitors, and there are clinical trials right now looking at farnesyltransferase inhibitors. HER2 is frequently upregulated in inflammatory breast cancer, and we have clinical trials like the NOAA study, or in France we have the Beverly 1 and 2 study looking at HER2 targeted therapies in inflammatory breast cancer. And you can have a high level of PCR in this very aggressive type of disease in inflammatory breast cancer, up to 28%. VEGFR is also upregulated in inflammatory breast cancer, and we have some clinical trial with bevacizumab or anti-VEGFR drugs showing also good results in terms of treatment. You can see here this patient with an inflammatory breast cancer with a complete response with bevacizumab. But I think that now we have more and more data because we have a consortium, an international consortium with people from Europe and United States, in particular in the MD Anderson and in New York, that have collected the largest sample set of inflammatory breast cancer. And they have 137 patients with inflammatory breast cancer. And they can compare to a non-inflammatory breast cancer group. So they have found 443 genes that are expressed between inflammatory and non-inflammatory breast cancer. Of course, I'm not going to detail that, but we have genes that are involved in cell motility, for instance, that are in the inflammatory group. In this consortium, they have identified 4 robust inflammatory breast cancer sample clusters that are associated with different molecular subtypes. So they have found that the biggest difference is that they have very few luminal A, so the so-called ER-positive, low proliferative group by immunohistochemistry, and they have higher level of HER2 positive. They have 22% of HER2 enriched subtype, so which is the HER2 positive ER negative group. And they have developed an IPC specific molecular subtype gene signature of 79 genes. One of the most interesting findings was an attenuated TGF-beta signaling in inflammatory breast cancer. So, what is the explanation? TGF-beta has a central role in the process of EMT, the epithelio-mesenchymal transition. It's very important for the understanding of the carcinogenesis of the inflammatory breast cancer. Because here, with these results, we can assume that EMT is not the primary means of tumor cell migration and invasion in inflammatory breast cancer. And also, by the fact that we have the downregulation of TGF-beta, it's also the reason why we have less luminal A tumor, because usually the TGF-beta is pushing the proliferation of ER-positive cells. So we can explain the profile and maybe the carcinogenesis of inflammatory breast cancer in part with TGF-beta downregulation. This signature of 79 genes is also applied to a cohort of non-inflammatory breast cancer. And when you have this signature is in non-inflammatory breast cancer, the prognosis of the breast cancer is worse than if you don't have the signature. I will finish my talk on that. We have different data that could be very interesting for the inflammatory breast cancer patients with ALK alteration. So we had recently 2 papers, and we have other papers in the literature, looking at ALK rearrangement or ALK alteration in inflammatory breast cancer. So this is the paper from the consortium. It's a paper from September or October 2013. They found that they have activation of ALK more frequently in triple-negative breast cancer, and they look at 25 cases, and they found that they have alteration in 20 cases, so more than 80%. And in this paper, they do a lot of preclinical work and work on cell lines, showing that they can target ALK in this preclinical model. So it could be a hope for the patient, for instance, to use crizotinib that is used in lung cancer with ALK alteration. And they found, especially in this group, in this study, a higher copy number, not really translocation, only in 2 cases, but a higher copy number for ALK. There is another paper from MD Anderson where they look in 30 IBC, and they also look at the status of ALK gene and ALK expression in inflammatory breast cancer. They didn't find any rearrangements. They look at transcriptome and they find that in some cases they have an overexpression of the ALK pathway, and they also found that they have gain, like here, in ALK copy number, 4 copies instead of 2 copies usually. The last work that has been published by the International Consortium, it's still in press. They look at the signature of response to neoadjuvant treatment. And it's a signature of 6 genes. And you can see here that a large part of the signature is immune genes, and the other part is P3K pathway. And for the tumors having these signatures, the level of response to neoadjuvant chemotherapy can be very high. And at the opposite, if you look in terms of prognosis in a series of breast cancer, it's really a very huge in terms of difference of prognosis with the signatures and without the signatures of inflammatory breast cancer. So in conclusion, we have recently had very interesting new biological data on inflammatory breast cancer. And I think that we see better the profile of those tumors. Half of them are ER negative. 40% of them overexpress HER2. 50% of them overexpress androgen receptor, and to a lesser extent EGFR. E-cadherin overexpression is a hallmark of inflammatory breast cancer, along with p53 mutation and overexpression of MUC1 by immunohistochemistry. They are more frequently classified by molecular subtyping in the HER2 and basal-like subtype, and the luminal A group is almost absent in the true inflammatory breast cancer. And recently, we had data suggesting a possible activation of ALK pathway related to an ALK gain copy number and amplification, up to 80% of the cases. And discriminatory genes between inflammatory breast cancer and non-inflammatory breast cancer are associated with cell motility, cell adhesion, like cadherin, angiogenesis, and some of them can be potential therapeutic targets. Thank you very much.